This slide presentation details many of the presentations that you will see in patients after they've been diagnosed with a cerebral vascular accident or stroke. Very important to consider a few things with patients that have been diagnosed with a stroke. Very, very important to always monitor vitals. Vitals can change rapidly, and high blood pressure is very much associated with stroke. Thinking about that in the clinical situation, if you've been working with a patient and you know their current level of function, and then you start working with that patient the next day and they are radically different, they have radically declined in their presentation and their ability to function, that would be a time to notify someone as soon as possible, because it's quite possible that that person may have had another stroke. The only way they know is they're going to do some sort of imaging, and other people will assess them too. Another thing to be aware of is that if patients are on anticoagulant therapy, which, as we've talked about, is a common medication given to help break blood clots, then they are at risk for a hemorrhagic stroke. Okay, they are more at risk for a hemorrhagic stroke if their INR is elevated. So consider anything above 3, an INR of 3, to be essentially an increased risk for a hemorrhagic stroke. Patients post-stroke are also 10 to 75% more apt to have a DVT. Okay, thinking about DVT presentation, you're looking for pain with weight bearing, you're looking for increased redness or warmth or swelling in an area. It can be a DVT that's affecting the upper extremity and or the lower extremity. But you should know that if you suspect a DVT in this patient population, there's no therapy at that time, or you're not going to get that person out of bed. They have to be screened for the DVT first and then treated before therapy is to proceed. Also, many of these patients have respiratory insufficiency and may be on oxygen. This slide just shows some common problems of post-CVA that you may see. Note that seizures, about 10% of individuals that have experienced an ischemic stroke can suffer from seizures, and 34% of patients that have had a hemorrhagic stroke may present with seizures. Really important thing to consider before you make somebody supervision level, always consider min assist, especially early on after CVA. Patients can present with cognitive problems, and we've talked about all the cognitive problems that are listed here: alertness, memory, attention deficits, executive functioning, all of those things that are those that you should screen for when working with a patient post-stroke. Okay, visuospatial and perceptual disturbances. When we were in neuroscience last year, we went over hemianopsia. Okay, lots of different locations where a patient can have hemianopsia. Notice that the figure on the right-hand side of the slide shows that from the very front of the brain all the way back to the occipital lobe in the back of the brain, there are optic nerves, optic tracts, optic chiasm. You also have the superior and inferior optic radiations further back. Anywhere that the brain has been affected may also affect vision in this patient population. So please go back and look at the different visuospatial deficits or the different kinds of hemianopsias that we talked about in neuroscience and refamiliarize yourself with those. We talked a little bit about neglect, agnosia, and apraxia early on in the semester. And in the next few slides, I'm going to expand upon each of these and talk a little bit about how to examine patients for the presence of these problems. Communication deficits, we've talked about aphasia, you have Broca's, Wernicke's, it could be global, and dysarthria, which is just trouble enunciating the words. And then finally, we've talked quite a bit about spasticity and the use of the modified Ashworth scale to document the amount of spasticity that a patient has. You should also be aware of the fact that approximately 20 to 40% of patients post-stroke will present with either hypertonicity or spasticity. So neglect is something that we've talked a little bit about earlier in the semester. You should know that it is, the majority of the times, a right parietal lobe lesion. Okay, this is most of the time. Occasionally, you will see patients present with neglect that have a left parietal lobe lesion, but this is relatively rare. Neglect can be of personal space. So, for example, a left arm or a left leg might not be attended to, part of the person's body. It could also be of a peripersonal space. That means anything on the left side that is relatively near to you or that you're using, the patient is not going to attend to. Example of this would be having a person sit down to eat a meal with a plate in front of them, and they might not attend to any of the food that is on the left side of the plate. So they're going to clear the right side of their plate. It's not that they're not hungry, but nothing on the left side was touched. Another example to detect neglect in a peripersonal space would be playing the game Connect 4. If you're playing Connect 4 with a person, they might hear the sound, but they're not going to go and look on the left side of the game board. And finally, you can also have neglect of an extra personal space. And this is where the person doesn't pay any attention at all to the left side of the world. That whole side of the world is pretty much non-existent for that patient. That's a relatively weird presentation. Then moving on, if you're examining for neglect, pretty easy in the early on, the worst form of neglect, the patient's actually going to have difficulty turning toward their left side or even gazing or bringing their eyes to midline or going to the left. They might present with their head completely turned to the right side. So in that case, it's pretty easy to identify the presence of neglect for this person. Another test of neglect that we've sort of touched on previously is called double simultaneous extinction, or just extinction. Okay, you can check for extinction by checking peripheral vision. This is where we've talked previously about wiggling both fingers in the different quadrants at the same time on the left and right side. If the person has neglect of the left, if they have vision on the left, but they're neglecting the left side, if you wiggle both your right and left fingers, they're only going to detect the right. Okay, same thing happens with light touch sensation. If you're touching the left side and they have sensation on their left side, when you touch both the left and right sides of their body at the same time, they're only going to detect the presence of sensation on their right side. Okay, another is known as the line bisection test. And the line bisection test itself is just having a straight line placed in front of the patient, and then they're asked to put a line perpendicular to this line at about the middle. Okay, if a person has neglect, their line that's perpendicular is going to be much far displaced to the right. It's not even going to be close to the middle. Another, I talked previously about food left on the plate. You can see more food left on the left side than the right side. And finally is the clock drawing test, and that's something that we've talked about previously as well. Okay, we've also talked previously about agnosia, and that's the inability to detect something with one of your senses, even though you can detect it with another sense, and the sense that you're having trouble with is working just fine. It's just not working to communicate information to you. The first kind of agnosia is known as visual agnosia, and it's a lesion of the posterior parietal association area. And it could be either the right or left hemisphere of your brain, and it's just the inability to visually recognize an object, despite the fact that your eyes are functioning normally. One way to detect the presence of a visual agnosia is to have a patient name objects placed in front of them. For example, a bell and a ball. Putting a bell and a ball in front of a person and then asking them to name those objects would be very difficult or impossible for that person to do. Next kind of agnosia is known as astereognosis, or it's also called tactile agnosia. And again, it's a lesion to the posterior parietal association area, and again, it's also the right or left hemisphere that's been affected. And this is an inability to recognize objects just by touching them. Okay, one way to detect the presence of this problem in a patient is to ask them to locate objects in a pocket or a purse. So for example, if in a purse or a bag of some sort you put a key and a quarter, and you ask that person to reach into the bag and pull out the quarter, they could pull out the key because they presented with astereognosis. And finally, there's also an auditory agnosia, and this is something that a speech-language pathologist is going to test for. It's typically a lesion in the temporal lobe of your dominant temporal lobe. So for most people, it's going to be the left lobe of the brain. And it's simply an inability to recognize non-speech sounds or discriminate between them, even though your hearing is intact. Okay, example of sounds that might not be recognizable to people with auditory agnosia would be the difference between a doorbell ringing and a telephone ringing. Here's another video, and I like this video because the patient has ideomotor apraxia, and you can see some nice examples of her difficulty with performing or understanding these tasks. Okay, in general, ideomotor apraxia is inability to make proper movement in response to a verbal command. So when working with this patient population, you want to use as many tactile cues as possible. Your words aren't going to work as much. Okay, you're asking them to do something, they're not able to do that. They have ideomotor apraxia. So use tactile cues as much as possible, and that'll provide success in working with this patient population. The other major kind of apraxia that you might see is known as ideational apraxia. Okay, ideational apraxia is different in that the person has the ability to move all body parts, and they understand the commands and they can hear the commands, except if it's a complex task, they're going to have difficulty putting the movements together. So a classic example, and if you want to take a minute, you can watch this video as well, is putting on a shirt. Right, and in this video, you're going to see that the putting on a shirt, you have to know what side of the shirt's up and down. You have to know how to put your arm through the sleeve, all of those things. And then once you get one arm in, then you have to put the shirt around and put the other arm in. And this combination or the sequence of movements with multiple steps and multiple thought processes is going to be very, very difficult for an individual with ideational apraxia. And hopefully that helped to have you understand the difference between the two. Ideomotor is you can't do something in response to a verbal command. Ideational is you can try, but you can't coordinate or sequence the movements properly to execute the function or execute the task. So regardless of whether it's an ischemic stroke or a hemorrhagic stroke, there are some other patient presentations that you should be aware of. The first is dysphagia. There's also a very large difference between patients that have right versus left hemiparesis or hemiplegia. And then there's something called Pusher syndrome and pseudobulbar affect. Okay, the next few slides are going to take each of these presentations in turn and give you a little bit more information about what exactly they are and what to be aware of. Dysphagia. Okay, patients with dysphagia have difficulty swallowing. Okay, there's a couple of videos that are on this slide's presentation. If you click on the swallowing function, you'll see an example of normal swallowing function happening in an animated form. Next, there's something called a barium swallow. So there's a video on a normal barium swallow. So this is a person that isn't having dysphagia. And then finally, there's an aspiration. So it's a barium swallow where a patient is presenting with aspiration. And aspiration is nothing more than food or liquid, solid or liquid food, may not go down the esophagus, okay, due to the dysphagia, the liquid or solid food actually ends up in the trachea, and you might not know it. I mean, the aspiration can be silent, but it's important to remember that if the person is aspirating, this can lead to pneumonia. Big issue. Okay, so you want to catch, or so it's actually the speech therapist's job to look at dysphagia in the patients that we're working with in the hospital or clinical setting. And you should be aware of whether or not your patient has dysphagia, so you know whether or not you're allowed to give them regular water if they are thirsty. Okay, so just take a few minutes and look at each of these videos, and it'll give you a little bit more idea about what dysphagia actually is. As I said, if you're working with a patient that has dysphagia, there's a couple of compensatory strategies you need to be aware of. They might be on thickened liquids. There are 4 different grades of thickened liquids. Those include thin liquids, which would be basic water, not thickened in any way. That would be a normal swallowing diet. The next is nectar thick, honey thick, and then followed by that is pudding. Okay, and these thickness levels are prescribed by the speech therapist, and we just know to follow it with individuals that have been diagnosed with dysphagia. You have to look to see what is recommended for this patient and actually thicken liquids before you give them to the patient. Okay, you may also recommend a chin tuck during swallowing. Okay, if you chin tuck, you're less likely to aspirate. And also recommend that the patient has smaller zips as opposed to large gulps of liquid. Again, as I said, the treatment for dysphagia isn't something that we're going to administer. The speech therapist is going to do it. And they can do vital e-stim or vital stim for on the muscles that are involved in swallowing. They might use biofeedback with a mirror. And another thing that we can be conscious of is the posture of the patient is going to be important for swallowing. So you want a good upright posture before you go into have that person swallow anything if they have dysphagia. Okay, next. Consider that if a person has had a stroke, it's either going to affect their right side or their left side. Okay, regardless of which side has been affected, you may expect sensory dysfunction. You might have a visual field deficit, and you could also have cognitive impairment. Right or left side, those things are going to be possible for either patients with right or left hemiparesis. You should also know that if a patient has left brain damage, so they're going to have right-sided weakness, okay, they're more apt to present with speech and memory deficits, and their behavior is going to be really slow and cautious. So this is the patient population that knows that their right side isn't working very well, and they're going to not really want to put any weight through it. Okay, they're not going to trust it. So they're going to be really slow, really cautious, and when you ask them to put weight through that extremity, they know it's not working, so they're not really going to want to do it. Okay, that's left brain damage. Now, on the right-hand side of the slide, you have an individual with left hemiparesis. This is due to right brain damage. Okay, left hemiparesis. This patient population is going to be more apt to present with perceptual and memory deficits. Think about neglect and anosognosia. And they're also going to demonstrate quick and impulsive behavior. This is a dangerous patient population. Not a good idea to give them the opportunity to get up by themselves, because if they don't know they have any deficits, they're just gonna try and walk and just go for it. As far as being able to work with this patient population, you have to be careful that they're waiting for you and moving slowly enough that you can keep an eye on them and make sure that they're not going to step on a weak lower extremity, for example, when you're not ready for them to do it. And this is just practice. But you should be aware there's a very big difference between patients that demonstrate right hemiparesis versus left hemiparesis. Okay, moving on. The next patient presentation, which you have seen previously when we were looking at the movement system diagnoses out of the Sheets et al. Article, and this pusher syndrome is known as a perceptual deficit. Okay, kind of a unique presentation. The lesion has actually been localized to the posterior lateral thalamus. And this is where the person doesn't have a good feel of midline. So you go to sit them up, and they might use their strong upper extremity to push toward their weaker side. Okay, and that's what you see at the picture here on the top right side. Not only is he, if you look at the picture, not only is he using his upper extremity to push, if you look, he's also using his right lower extremity to push him over on the left. He really feels like he's going to fall when he's in midline. So his perception of vertical is off to the left quite a bit. Okay, finally, last patient presentation is known as pseudobulbar affect. Okay, it's also called emotional lability or emotional dysregulation syndrome. And it occurs in lesions affecting the frontal lobe. Okay, and it's characterized by emotional outbursts of uncontrolled laughing or crying that are inconsistent with the mood. And the problem is the patient isn't able to control these outbursts. So you could be working with them in therapy and, you know, telling them they're doing a great job and everything's wonderful, and they'll just start breaking down and crying for no reason. There's no reason for them crying, and they are very embarrassed by the fact that they're crying. They don't understand what's happening, but they just know that they're crying. You know, and conversely, somebody could be talking about a funeral or a loved one who died, and the person will just break out laughing. Okay, just hard to conceive of, and you know, it leads to confusion as to why is this person behaving in this way. Well, it's quite possible that they have something known as pseudobulbar affect. So if you suspect pseudobulbar affect in one of your patients in the future, please notify the referring physician, and there is medication that they can take to help with this problem. Now, there's also a video, gives you a little bit of information about this individual that has been diagnosed with pseudobulbar affect. So please go ahead and take the time and watch the video and gain a little bit more understanding about what to expect.